It's a great honor and a pleasure to be here this evening to talk to you about family-centered care. I'm going to dedicate my remarks to Queen's University, Belfast, to Tiny Life, and to the Northern Ireland Neonatal Network, because the work that you guys do is different from each other, but integrated and really moving the field forward. So it's a great pleasure to contribute to that and help cheer the cause. My background, I'm glad you didn't say anything, because usually you go on and it's embarrassing, but I'll give you the short version. I'm a neonatal nurse from way back when. I won't say what year, but you might be able to guess from some of the remarks that I make in the talk. That was my clinical background. I then went into research to study infant pain in a time when we were still debating about whether infants felt pain or not, and how they expressed that and what it meant, and did it have any long-term effects, which we have some expertise in the audience on that regard with Dr. Ruth Brunel here. Then through my work with families around taking consent from parents about doing pain studies on their babies, about just being part of the field, and we'll take a little bit of a history tour in these remarks. I came to really be interested with family-centered care and how we could really understand the perspective of the families and become more aware of the contribution to care and the partnership that we needed to form. So my work has kind of moved into more around the care of the whole family and across the age span, although I keep coming back to my first love, which is neonatal care. I did, as Fiona mentioned, spent about 10, almost 11 years in the UK, based at Institute of Child Health at Great Ormond Street, with a joint appointment at King's College London and the Great Ormond Street Children's Hospital. And that was a fabulous experience, and learned a lot, and saw how many different ways there are to get to good care. We don't all train the same way, we don't all organize our health systems the same way, but there's lots of different ways. There isn't just one right way. And that'll be, again, the point of the discussion I hope that we can have today as we go through this journey. So with that, I can tell you more stories, but we'll have to take a glass of wine or two before we can get into that if you want to know more of my background. But I'd like to invite you to join me on a journey for about the next half hour or so about what the neonatal unit is like for families, what it means to families, and how we might help enhance or make that journey really difficult for families. And talk about family-centered care, why, most importantly, why it's important, but also how and what it really is, because the meaning of the term has changed over time. Sometimes when I talk to a lay audience, how many people here are parents or don't have a clinical medical background? Okay, great. Nice to have you. Thank you. Sometimes when I talk to my friends or family about the research in family-centered care, they look at me and you can almost see a little speech bubble coming over their head saying, well, of course, why wouldn't healthcare be family-centered? It sounds like motherhood and apple pie. But in fact, if those of you who have been experienced on the patient side and then also on the healthcare delivery side, a lot of what healthcare is about is driven by the needs of the system, not the needs of the patient. And there are many places where things can go awry. And so it is important that we do understand it and study it and see, what we can do. So although sometimes it is about studying the obvious or making the invisible visible, it's an important step. So let's take a tour to a very interesting and different land.
Don't the lights down at all?
Maybe a little bit, I think, because there'll be a lot of photos and they don't show up well. So this is sort of a. How many of you have been inside a neonatal unit? Okay. Most everybody, but not everybody. So for some of you, this will seem normal and your everyday, it might be your everyday workplace, right? So if this is the normal place. Well, recently there's a great series of articles by a mother who had a very preterm baby, but who also was a journalist and her husband was a Pulitzer Prize-winning journalist, and they wrote about their experience and it's published in the Tampa Bay Times. And she describes it, and I've heard other parents describe this as kind of like an alien planet where babies grow in these little pods. You know, it's very foreign, can be very scary. And, you know, for those of us who end up making that place our workplace and spend our time there, it becomes normal, but it's not normal. It's not the normal everyday thing that parents would expect. And in fact, many parents end up with babies in the intensive care unit when they were, you know, up until the moment of delivery, emergency delivery, they were expecting a full-term baby, and they end up with a very preterm, very fragile baby. They also maybe were expecting to stay in the hospital about 2 days and go home with all the fanfare of a royal birth, and then end up having to spend, you know, many months in this foreign land with watching the baby grow in this pod and tethered, you know, to the bedside, trying to learn a new language of the neonatal intensive care, trying to figure out what the customs and rules are of these people or these other beings that are carrying, you know, wearing different clothes, acting different, you know, again, having an uninterpretable language. So it's really quite a shock and quite something to get used to for parents of a new baby in intensive care. And again, for many of us who go to work there every day, this is ordinary, and we have to always try to keep that perspective in mind. But some might say, well, that's just the way it is, right? You know, these babies are very sick, they need specialized care. You know, the best thing to do is to just turn it over to the professionals, let them do their job, and then, you know, when we get the baby in as best shape as we can and they're healthy enough to go home, we hand the baby to the parents and then they can start their work, right? But, so that has been an attitude. That's been an attitude for many years of neonatal care, that, you know, that this is sort of the division of labor. But that attitude, as I'm hoping to convince you in the next minutes of this talk, is really not been shown to be effective. That the work of the neonatal unit can't be divided so neatly into what the nurses and doctors do for the baby and then what the parents do for the baby when they go home. What it turns out to be is that actually that's about the worst thing you can do, is to separate the baby from the care of parents in the unit while the baby's receiving intensive care. And that the need for parental contact is equally as important to the high technology that medical care can provide. And we need as much high touch as high tech. And that's, again, a theme I'm hoping to convince you of if you're not already convinced. This is a photo from Dr. Niels Bergman from South Africa. He's been a pioneer in bringing something called kangaroo mother care or skin-to-skin holding into from something that was developed for low-resource countries, we'll talk about that in a few minutes, into the developed world intensive care setting, where it's not about not having enough technology, but showing that actually we need both. And so these are, you know, this is kind of the new frontier of the neonatal unit with families, primarily mothers and fathers, but sometimes you have even grandmothers or other family members giving a spell to the parents, and actually, instead of the baby being in a plastic pod, being cared for in very close contact with the parent. But that's not how it always was. If we take a journey, a small detour in our journey back in history to the early days of neonatal care, it was very much run and controlled by nurses and doctors in a very sterile environment where parents were kept out and only ever able to look through the window and see the tiny baby there. And that persisted quite for some time, thinking that we had to keep the environment sterile, we couldn't have any outside contact with people who weren't health professionals. And what that persisted even till into the 50s, 60s, and 70s, really, before things really started to change. It was very much off limits to families until babies were ready to be discharged. But what began to be noticed as early as the 50s, but really not until the 70s, 80s, was that despite all that best effort, babies weren't developing as they should, and oftentimes their babies were growing up in the neonatal unit, some of them staying more than a year or 2 years. We certainly had those children when I was in clinical care. And parents would do their best to keep up the visiting during the very, very limited visiting hours, try to maintain contact with their baby, try to develop relationships with their baby's care team, but it was very difficult. They didn't really have a role. They saw the babies responding to nurses as if they were their parent, especially if there was primary care nursing. And so babies were developing with surrogate nurses as surrogate parents in some ways, or just a rotating revolving door of different caregivers, and never really attaching or developing a relationship bond with any particular person. There were some levels of abandonment. There were high levels of depression in mothers of preterm babies. There were a lot of babies going to foster care, because the stress and the strain of parenting after the baby was handed to the parents, oftentimes with long-term health needs. It was just too much, and they couldn't sustain it. So we were in this place where we had, all this wonderful new technology. We could, the survival statistics were growing by leaps and bounds, and yet the quality of life for babies wasn't what the technology promised what could be. So that took us to about the late 70s, early 80s, and things started to change. They changed for a number of reasons, but one of the most interesting aspects of this was actually something that came from a developing world country, where they, in Colombia, where they had very low resources, and they had some donated incubators from the States and elsewhere that would work for about a few months and then break down, or the electricity would go out. And so the babies were dying. They weren't surviving. There was terrible infection rates in the hospitals. So the hospitals weren't a safe place to receive care. And two doctors in that setting, Edgar Reyes and I forget the name of his colleagues, developed what they called kangaroo mother care, where they asked the mothers to keep the babies skin to skin on their chest, tied with a simple cloth, and to keep that baby there 24 hours a day, 7 days a week, breastfeed exclusively if at all possible, and continue, and to get out, and as soon as the baby was stabilized, to do the kangaroo mother care at home so that the baby was kept out of the hospital. And they, to their surprise, saw a phenomenal drop, a huge drop in infant mortality quickly, and also in long-term mortality and morbidity. Infants didn't have failure to thrive, they were able to grow, and also, surprisingly, their abandonment rate of the babies dropped very dramatically. There was a very high problem of families just giving up their baby, thinking that they were not going to survive, and just leaving. But they all started doing the kangaroo mother care and becoming very connected with their babies, and the babies surviving and thriving. So that was fantastic, and that to this day is something that's really trying to be spread and scaled throughout low resource countries. And the statistics, the reviews on kangaroo mother care in those settings consistently show that if you can achieve good uptake of kangaroo mother care in low resource settings, that you can save vast numbers of preterm babies to survive and grow to be healthy. So it's very exciting. But back in the States, or in Europe or in Canada, during that time, we had functioning incubators, we had antibiotics, we had good infection control, so there wasn't the same impetus to try kangaroo mother care. But at the same time, there was other work going on around understanding infant development and really appreciating the early capabilities of the infant to interact with this caregiver. This is a picture on your left. Just shows that one day old or 2 day old baby, very young baby, being able to imitate a human expression, that the way that the infant could modulate their behavior and regulate the interaction was a new skill that we hadn't really appreciated that babies could have. That then spurred further research, of which Marshall Klaus and John Kennel were integral in introducing kangaroo mother care and other close contact between parents and babies as in a high resource setting, not to try to save the baby or reduce it from mortality, but to try to improve the development of the attachment relationship between the baby and the parent, recognizing how important that was for the baby's development, and for also, we learned, for all kinds of things in terms of the hormonal regulation of the mother, breast milk supply and being able to breastfeed, just attachment with fathers, the whole gamut. It was really became quite apparent that for parental mental health as well as infant development, we needed to figure out a way to have more close contact, even though it wasn't necessary for the baby's immediate survival. So those two kinds of things sort of converged, and we started to develop what's called family-centered care. So from the period of time where parents were excluded from the unit, now we saw in the 80s, come on in, welcome. We saw in the 1980s where parents were allowed in, parents had visiting hours and could spend maybe longer periods of time there. But still, the professionals in the units were firmly in charge. You know, we set the hours, we set what parents could do, we, made the rules, and we really controlled things. And I say we because this is the time when I was really at the bedside. We talked about parent involvement, and we thought we talked about parent empowerment, but looking back, I'm not sure if that's really what we understood. We didn't understand the term clearly enough, but it was always on our terms. But it was still a huge step forward, even though it wasn't what we would call family-centered care today. And I do remember, that the impact that we had, when we first, as an experiment in our unit, we thought here was a baby who was still on the breathing tube, ventilated, that we would try and get this baby into the mother's lap to hold. Not skin to skin, but just even to hold for the first time, even though the baby was still connected to life support and other breathing machine. And we were all very worried, and we worried about the risk, but the look on that mother's face and the way that the baby responded by increasing their oxygen saturation and having their heart rate stabilized, that memory still sticks with me to this day. And I also just recently talked to a mother who has become quite active in a local foundation and charity to support families in family-centered care in hospitals. And she, when I said that I did work in family-centered care, the first thing she said to me was she still vividly remembers when her now 20-year-old daughter was a preterm baby, and how she was so scared to go near the bedside, wouldn't touch the baby, was really, just afraid and overwhelmed. And the nurse came up to her and said, why don't you talk to her? She can hear you. She knows your voice. And that encouragement, that recognition that there was a special relationship there, and that the mother had something that she could contribute that was different and special from what the nurses and doctors, that's the first thing she says that comes to her mind when you mention family-centered care 20 years later. And that completely shaped their relationship, and also her willing desire and passion to go on to try to help other units and other hospitals achieve family-centered care. So even though it wasn't perfect or what we would call our ideal today, progress had really been made. But between that time, so between the 80s, 90s, and into the 2000s, family-centered care has really become a movement. And it's a movement not just in the neonatal unit, but across all healthcare settings and across all populations. Although I'm proud to say from a neonatal perspective, I think the movement was really led by neonatal parents such as Helen Harrison in the second half of the 90s, and nurses such as Bev Johnson, neonatal nurses who now leads the Institute for Patient and Family-Centered Care. But they were mostly grassroots movement, many local, some combinations of healthcare professionals and parents, all wanting to improve quality and safety in hospitals and healthcare by helping families to be active parts of their loved one's care and not just recipients, passive recipients of care. So today, if you were to Google family-centered care, you would get all these different organizations to come up that are specific to family-centered care, have family-centered care in their name, and many others, like the ones who are sponsoring this talk tonight, that have family-centered care as a vision and as a mission. But again, it's across the spectrum, across all age groups, and really making the field coalesce and clarifying what the concept really means, what it is and what it isn't. So let's just review the core concepts as they stand today. So it's not just about family-centered care isn't just about having open visitation for parents or having a mother be able to do kangaroo mother care for an hour or two a week. It's much more than that. It's about having a belief and a philosophy that the planning, delivery, and evaluation of healthcare are conducted in collaboration, in partnership with parents and families, not parents and families being the objects of care. And it has some key components about information sharing. And again, that information sharing is two ways. It's not just about the health professionals telling families what they should know or what they need to know or what they should do. It's about families and patients themselves being a valued source of information about how care should be delivered, about helping to identify problems in not just the individual's care, but also the system of care, the processes of care. It's about respecting and honoring differences, and that there is no one right way, and there's not just a certain pathway that all families need to march through, or that all patients need to adhere to. It's about a true partnership and a negotiation of what that care will be to meet the needs of that individual patient and family. And that it's always, all care is delivered in the context of the family and the community from which that family comes from. So it's sensitive and engaging of the community as well. So that's what family-centered care means today. And so from that, that kind of overview, and I'm giving it just a really quick overview. There's much more depth to it now, and there's lots of resources that you can find about that if you want to dig deeper into it. But just to give you that as an overview, and going back to the neonatal unit, over the last decade or so, we've really tried to improve and kind of up our game, if you will, on how to really incorporate all aspects of family-centered care, not just single interventions of it. So some of the ways in which that happen at the individual level are around helping parents and other family members, siblings, etc., to be closer to the baby at the points at which they want to and can be most effective. And this can be around general development, and certainly the image that always comes with this is about holding babies, but certainly around procedures. And this is the slide on your right shows a baby getting a heel stick for a blood sample being held skin to skin. And again, lots of research now to show that that's in a very effective way of preventing pain in the baby and in helping the family and the parent really feel valued and doing a unique role in comforting their baby, which is one of the primary important roles of parenting, right? Is to helping your child both prevent pain and cope with pain throughout their childhood. So these are examples of interventions on the individual level, but it's not enough to just do that. We really have to do the next level around partnership in care and care decisions. So right now, there's a lot of emphasis. You'll see many units trying new strategies around changing how they make decisions around care. So going from the traditional medical and nursing rounds where the professional caregivers for the patients gather and talk about the plan for the day or the plan for the week, look at all the lab values, et cetera, moving from something like that to something where rounds and decision makings never happen without parent input in some shape or form, so that the rounds are done with the parent and parents are contributing information and sharing their observations, and that decisions around the care plan are done jointly. So that's something that are being evaluated and shown to be really positive in many studies. But it's not something that you can just wave a wand or hit the shift key and say, okay, we're going to do parent-centered, family-centered rounds now. Parents are going to be included in rounds. I mean, it's a much deeper cultural change that has to happen. And there's all kinds of other purposes and roles that rounds serve. How are we going to do our teaching? We do our medical staff teaching during our rounds. If we have parents there, that's going to slow us down. How will we get to all the babies and do the teaching? What if we're talking about something esoteric and it's not going to affect them? What about other parents hearing about the baby next door's condition? How is that going to affect privacy and confidentiality? So all this stuff comes out as soon as you start thinking about, oh, well, we'll just encourage parents to join rounds. How do you help parents know enough about the language of rounds and how decisions are made so that they feel that they can contribute? They know how to talk the language. They, what about the nonverbals and how people interact? The studies where we've done videotapes of rounds have been very interesting in revealing some things that are discouraging to family participation, even though we verbally say, do you have any questions? How do you think your baby is doing today? And then turn away. So it's not a simple change to do any of these things, but it can be incredibly empowering and also really changing how the dynamics of caregiving in a very fundamental way. But that's not even enough to do family-centered care, to say you're a family-centered care unit or hospital, to leave it at processes like that. You really need to think about going to the next level and involving families in fundamental decisions about how your health system and health service work at the hospital level and beyond. So this is an example. This is a family advisory committee from one of the big children's hospitals in the States, which is made up of parents this is across the hospital, so it's children of all ages. There are some teenagers participating as well in the group. There are families who have children who have survived and some who have children who have passed on, and also representatives of parent support groups and other local groups. And they all come together to advise the hospital in all aspects of its work. So from how to design a new unit, how to design a new building, to giving input into the processes of care. All the units, if they're doing a new protocol, would bring, that involves families, which most of them do, would bring that for their review. They look at the language, they look at how it's presented, the process for rolling it out. They go to training sessions for new orientees. They go to the universities and speak to the new residents and nursing schools from the parent perspective, so that they know as they're training how the things that they're learning to do, the protocols, how they communicate with families. They hear directly from people who are part of that care. So this is kind of the new frontier of family engagement that is being explored. here are just some examples about how that family engagement has influenced the design of the NICU. So here's like a typical way that nurseries used to look with the, the big barrier and having to be buzzed in and to a much more inviting approach, although sometimes you would still see this being, again, a gatekeeping point, parents still be considered visitors. Some hospitals have taken the visitor language out of all printed material for families. They give families special badges or some other kind of identification so that they don't have to stop and check in the way other visitors might. So again, you can take it part way or you can take it all the way, depending on the culture of the unit. Again, just an example of involvement in the design stage of a whole new build. What we saw in the 90s, 2000s were the standards for hospital design being enlarged to make sure that there was space for families. So many, even the minimal standards were that you had to have enough square footage so that there was a space for a parent, and you had to have a comfortable reclining chair so that a parent could do kangaroo care for a period of time and not have to do it in a very uncomfortable upright chair. So at the very least, you now saw a space for a parent at the bedside as opposed to them feeling like they were trying to force their way or be in the way. And also space for the family off the unit so that there would be a lounge for parents to have some respite for them to be able to take a break as well, and for siblings to be able to be encouraged to be there as well. So we did see some movement, but then we also saw some difficulty and some backlash as well, in that sometimes it would just stop as, well, we're doing that, we're asking our families for their views on patient satisfaction. We've tried asking families what they want done for their baby, but they didn't tell us anything. They just said, well, we don't know. You decide. So again, you'd hear things like this where, you can't ask people what they want for in terms of their care when they don't know the options, but they don't know what the benefits and burdens were, where you haven't, enlightened them or allowed them to be with you on that journey of care. Some units would log how parents were visiting and score themselves on whether they had parents visit more. Well, it's not so much about how much they visit, it's what they do during the visit. Are they sitting there being passive, just watching, holding vigil, or are they actually actively involved? So some of these things in some ways gave family-centered care a bad name for a while, and it became, oh, it's something we need to do, we're giving lip service to it, but not, that it lost its meaning as something being valuable and important, because there were some bad experiences early on and people would give up early because they didn't take it far enough or didn't think it all the way through. And then there are the real-world challenges faced by families. So, and I even still, having lived in the UK and now gone back to the US, I still think it's better here in terms of the social safety net for families. I know, and having talked to Allison recently about this, that that there is not much of a safety net compared to what's needed, but it's still, I think, better than what's happening in the States right now. It was quite a shock to go back and see how little support there is for families to both sustain regular engagement while their baby is in a long NICU stay, or what happens to them when they go home. And there's very little in terms of healthcare support or social support for them to be primary healthcare. It's quite a struggle, and we keep hoping with the Affordable Care Act and our new our health insurance governmental scheme that will change, but we've yet to really see that. So there are a lot of real barriers, and it's challenging us as healthcare professionals to get outside of our little four walls of the NICU to deal with some of these issues. And if we really want parent engagement, then we can't just leave it to somebody else's job to figure out the system to advocate for change, and we need to be part of that as well. And then again, as someone who grew up myself in the NICU, it's taken me a long while to realize that my responsibility is not just about, you know, working with parents once they're there. We have to figure out how to help support them to be there and to be engaged, knowing that they have many other challenges. This just shows another aspect of the dimensions, which is that, again, just as we can't wave our wand and have family-centered care happen among the health professionals, we also can't wave our wand and make it just happen for a parent. There's a developmental process to parenting and parenting engagement, and this is just a diagram from one of the studies from a former doctoral student, Carol Skeen, in Sheffield, where she very nicely mapped out through her ethnographic research how a parent is at first afraid to touch the baby and then starts to engage with visually and really watching the baby's behavior, and then after that, a period of time, starts to initiate physical contact, starts to then participate in caregiving, and then becomes confident in caregiving. And what supports that process is if nurses in the initial period where parents are afraid to touch and just wanting to observe, if they can model and demonstrate the techniques that they want parents to learn, but then as parents become more willing and able to engage, that nurses then start to hand that over and do that together with parents, and then step back and let parents do that engagement themselves. And we have some work to do here, because some nurses don't want to go that far. They want to stay, you know, they get their job satisfaction, and they get rewarded by the unit and administration for being good doers, not being good coaches. You know, it's not so much on the evaluations. You know, it's not in the time and motion studies when people come through to do efficiencies and are looking at workload. You know, it's about the doing. So we have to change that structure if we're going to support that process in parents. This is again just examples from our work about some of the barriers to parent involvement that are internal to parents, and these aren't things, you know, necessarily. So although some of them are where the staff have had a contribution, but you hear constantly from parents that they're afraid to be in the way. They don't want to do anything that will you know, take nurses and doctors away from their important work and have the attention be on them. You know, they do see how nurses and doctors and other healthcare professionals interact with their babies, and they watch, you know, who's caring with their baby, who's, you know, looking like they're not you know, really engaging with the baby. So they see these things and they worry about them, and they worry about the power differential between themselves and the professional caregiver. And Kelly French, who I mentioned earlier, tells this amazing story about, well, it's not amazing, it's just amazing to hear it in her own words, but I think it's probably fairly common among other families. While she was at the bedside, you know, hours and hours waiting and watching her baby, her husband was home often making cookies for the staff, and she asked him, like, why are you baking for the staff every week? And he says, I just want them to really like us and really like my baby and our baby, and if something goes wrong, maybe they'll run a little faster, you know, to get to the alarm or to help the baby. So that was his way of coping, is by making, you know, and trying to get, you know, feeling that there is this power differential and that so much of their baby's survival was in the hands of these professionals. So, you know, that's something that we have to help parents to along that journey, and how their contribution is as important, and that they can tell us when things are negative experiences for them, or they can tell us if they observe things that aren't to a standard that, you know, that they've come to expect, and that there won't be retaliation or there won't be retribution in the caregiving. That's a real fear of some. Just really quickly, just want to show you this a little video clip of a nurse teaching a father how to have contact with his very tiny, very fragile baby that's not going to be overstimulating and is not going to compromise the baby in any way, but also achieves that special parental closeness with the baby. So the nurses step back and is just talking the father through this, and then having the mother do it as well. And just as a quick little visual for you to see how that looks. So I would say, what's the current state of family-centered care? It's a work in progress. I would call it a work in progress. The March of Dimes, which is a large family prematurity prevention and family-centered care organization, just did a survey recently of all their sites where they have NICU family support specialists. So they've created a role that's often a parent of a former preterm baby, or someone with another social worker, other non-healthcare profession background, and they've funded and supported those specialists there just to work with families and just to support families. They did a survey of the units. So these are units that they've invested, to have a family support the program, they have to invest and raise some of the money from the hospital. So these are hospitals where they are intending to give family-centered care. They've made an investment, and yet only 60% of them welcome parents in the NICU at all hours. The other 40% have some restricted hours, like you can't come during change of shift is the most common, or there are certain hours where nurse handover is happening and parents have to leave the unit. Very common. And interesting, in the units where they are involving families in rounds, more of them involve families in medical rounds, but not in nursing rounds or nursing handover, which is also really interesting. So, things to think about and things to ask why or why not. Some data from the UK, from the POPPY study, the Parents of Premature Babies Project. They, again, interviewed a number of families, about 55 families, did in-depth interviews in England and in Scotland, and they had many examples of individual positive family-centered care activities that were being done in some units but not in others, by some nurses in the unit and not in other, or doctors, etc. But some of the other things that they found were that 1 in 10 of these units had no parent sitting room. So there was no place for a parent to go off the unit to take a break or have some respite after a long stay at the bedside. A quarter of those units had no single room for discharge preparation, so not even the fancy single patient room care that we're starting to see in the new builds, but they didn't even have a room where a few nights before discharge a parent could go with the baby and give the total care, but have the professionals nearby for questions or if something went wrong before they had to go take the baby home for real. So 25% of the units didn't have that service. The common thing was lack of psychological and social support services for families during these very high stress times. About half of the units had parent groups, but only a third had one-to-one parent support available. And only about half of them had some kind of home follow-up program where parents had support in the home or someone to come in and make sure things were going according to plan. So again, a work in progress, and I certainly can't see that we're here yet. Another big buzzword, I think in North America and probably here as well, is around safety and trying to improve on patient safety. And in the adult world, patient engagement and family engagement is a big part of safety initiatives now. And so we see posters like this all around saying, make sure that, number 2, make sure your healthcare professional cleans their hands and wears gloves. And these signs are posted around the hospital, so families and parents are supposed to just, go up to the surgeon and say, excuse me, have you washed your hand before you touch my baby, right? Well, this is what that feels like to a parent. I wouldn't have any problem with what to say. I just would have trouble saying it. I don't want to make the nurses and doctors feel like I'm telling them what to do or make them defensive, because I want to establish a good relationship so as to get the best care from them for my child. So again, that same issue of trying to balance, how much do you speak up, how much do you have input, but worrying about the the consequences of that and the potentially negative consequences like that. So lots of opportunities to move. Let's just quickly take a couple of minutes to go through some of the exciting things where things are going. When you talk about design, the new designs, and especially in North America and I think in Europe as well, there has been a movement towards single room design for a lot of reasons. But in the single room design, it's not just about what's at the baby's bedside, but there's now at least convertible bed space so a parent can spend the night in the room. But in fact, as I showed you in the earlier slide, the real frontier and what's happening in Northern Europe is about really creating a family room where the family can live with the baby and give and be really integral to the baby's caregiving in a meaningful way, not separate from the baby and not, again, expected to come and go, but to really be the main caregiver with the support of the healthcare team. So maybe that's where design will go. Again, you probably need different design to make that feasible, but it's not all just about design. Their statistics are really impressive from this. When they've looked pre and post the reorganization and the restructuring of the hospital, they have reduced total length of stay, and they've also seen some reduction in long-term outcomes such as lung disease that premature babies have. So probably because of less time on the ventilator and maybe more fine-tuning of the oxygen by having that motivated, constant parent monitoring. Where you also see experiments around technology. So when parents can't be close to their baby physically, can we really foster that relationship, foster their input in decision-making by using technology, doing things like Skype or other video conferencing? Can we help make parent support more accessible to families through social media and other virtual support groups as opposed to always having to do it in person? So, maybe technology can help family-centered care as well. But I think it's still ultimately, whether we have a technology solution, whether we have some change to the environment to make it more conducive, it's still about relationships and building a really good, strong partnership relationship, an equal partnership relationship between the family and the professional caregivers. And there are two really exciting experiments going on around this effort right now. One is called Family Integrated Care out of Canada, and Dr. Shuli's leading a 14-center trial where they're trying to replicate and see if they can scale up from their pilot work that showed, similar to the Stockholm experience, that if you have families meaningfully involved, and they have their protocol involves having the families basically agree to a contract where they'll come and give 8 hours a day care minimum to the baby, but then they really work through good, really strong nurse teaching and peer support from parents to teach parents all the aspects of nursing care, almost all the aspects of nursing care, and with support to really all the aspects of care, not just a selected, oh, you can change the diaper, or oh, you can give this drip feed, or oh, you can hold the baby while I'm doing the heel stick. So we'll see whether this can be translated and replicated and scaled across units with all different kinds of cultural mixes, unit cultures. We'll see if they can, have the same outcomes when that. But it's very exciting to even just be doing the trial. The other group is out of Finland and Northern Europe, using a protocol called the close collaboration with parents, where the focus is on a different kind of training for the healthcare professionals to really engage with families in a different way, and not just having a one-off in service or after the fact training. It's around bringing the health professionals up in a different culture of care and seeing how that then affects the relationship between families and the professionals. And then the Vaughan Network and their work with focus this year and last year on babies who have been exposed prenatally to opioids and other drugs, really trying to understand the psychological and social support needs of families and making sure that those things are in place. And so that, it's difficult to engage families if they're completely stressed, have other major mental health or other issues, have chronic pain, those kinds of things. So trying to really work around the psychological support services needed for families to make the engagement effective. So those are some of the frontiers. I hope you've enjoyed this tour and maybe thought about things a little differently than you maybe had before in terms of family-centered care. As I said, it's still a work in progress, but wherever the future lies, we think that it will, and to quote Bill Clinton, he was the one that said, or actually it was Hillary Clinton who did who not coined, but who popularized the takes the village. He was famous for, it's the economy stupid. I wanted to say it's family-centered care stupid, but it's a bit derogatory, I think. So I prefer Hillary's approach to it takes a village. But what family-centered care really focuses on is making sure that moms and dads have the lead roles, and also we'll take off on the Oscars the other night. So whatever the future, I think our values, have become clarified and will stay constant around communication, information sharing, choices, the respect for families, and the partnership, and coming from a strength-based approach as opposed to looking at deficits. So I want to thank, again, Fiona and the Queen's University Belfast group, Tiny Life, for all the fantastic work you do, and the Northern Ireland Neonatal Network. So thanks very much, and I look forward to
Thank you very much, Linda. Okay, wow, many opportunities. What do you think? Has anybody any comments? Any questions actually for Linda? Anything at all? That's quite radically different maybe to what we're used to, is it? What do people think?
Well, can I ask a question or just get your take on what you think? I have a feeling family-centered care has actually gone backwards. I mean, when I started working in the neonatal intensive care here, siblings were allowed in, parents, grandparents, siblings are never allowed in the end except possibly at the end of life. So I think we're going backwards. What do you think, or what do you see when you go around different
I think there's been some retrograde movement for a couple of reasons. I know, with some of the new virus infection outbreaks and pandemics, there was certainly that set family-centered care back a long way. And again, we're still, I think, recovering from some of that. I think there's been economic issues around staffing, around some of the support services. I really saw it in child life, being able to have child life services or play specialist services to support siblings, so that the logistics of having siblings be able to visit and stay for the brief time that they were able to hold attention with their new brother or sister, and then being able to be supported through play therapy in a separate area while the parents finished their time with the baby before they all had to go home. So those services might not be available, so there's nobody to look after the siblings. It all just became too hard, But that, again, it's going back to what that means is that whole system, our whole healthcare system, or that specific area, never really made it the whole way, so that when things get tough, you don't preserve those fundamental values. The fundamental value is still around, how the place will work for the staff, how the place will work for, the health service, not about how we can figure out this problem together to make it work for families. So, it's a challenge, but it doesn't mean we should give up the fight.
Any other comments?
Could I ask, you mentioned about involving parents more in the medical ward rounds and the nursing handovers. Can you tell us how you've actually got around the confidentiality concerns like
So
that?
there's lots of people are so creative when they put their mind to it. People are really, really creative. Some of it, we found in the States, there's the regulation around patient confidentiality is called HIPAA for short, HIPAA. It's got a long name that doesn't actually have anything to do with it, but it's the piece of legislation saying that, that you're not supposed to talk about patients and, keep confidentiality and it put some heavy duty fines against hospitals who were in violation of this and, really put the teeth into it. And people use that as a way, again, to regress back to a way that was more convenient by saying, oh no, we can't possibly, we have an open unit and we can't possibly have parents in the unit when we do rounds because somebody might overhear somebody say something about another person's baby and be in violation of HIPAA. Well, HIPAA doesn't say anything like that. It was just sort of an excuse to be able to go back to a more convenient way. But never mind that parents talk to each other anyway and share all that information anyway. So some of that was just about misinterpretation of HIPAA and making it be more convenient. But where there were issues and where there was felt to be wanting to maintain a sense of privacy, particularly when you had an environment that didn't, where you're all smushed up against each other. One of the most clever ways I've seen one unit deal with it is they gave parents headphones during rounds so that they could listen to music and tune into their baby, which is what they want to do anyway, right? They're not really all that interested in what's happening unless another parent has told them, you look out after. I mean, parents look out for each other's babies, right? But anyway, you can give them headphones and have them be listening to music while you're doing rounds at the baby next door. And that's just one example. There's lots of other ways that, can be some slight difference in terms of how they approach rounds and, how close they are to the bedside. The parent can step away as well and talk to so there's all different kinds of ways. It's about, figuring out the creative solution.
I was just going to pick up again in relation to the infection control challenge in respect to family-centred care. And I think, we had quite a bitter experience here in the province not that long ago with Pseudomonas, and as a consequence of that and other organisms, we're screening more and more. And when you screen, you find, and that's when you start. And I do think our new network will need to look at a very fine balance between participating in the whole family-centred care agenda and our infection control agenda, because unless we get that right, it'll continue to deteriorate because we are screening and every time something happens, everybody's screened. We're screening our workforce whenever there seems to be an outbreak. So as the next stage that we're going to screen our families who are coming into the unit, I think we need to be very mindful how far we take the infection control agenda in terms of balancing that against family needs and family expectations.
So it's about making sure you have a very articulate argument for what the burden is of that and what the cost is to the patient and family in this other dimension, and make sure that argument has equal weight. One of the most interesting things, which I don't know a lot about, but it seems that there's some new research around skin-to-skin holding in kangaroo mother care, that if it's done for a long period of time, that actually the mother's kind of good bacteria colonize the baby, and so that there actually is infection. They're understanding kind of they call it the microbiome of the mother baby, so that in fact one of our infection control strategies might be to get more babies held skin to skin instead of banning families from. So it's about delving deep into that and getting the willingness to engage in that instead of just saying no. What we find, again, what if you have a disruptive parent who has mental health issues and so we have to make a rule that that nobody can come because this one parent had issues and wasn't compliant. So do you make the rules around the exception, or do you try to figure out ways of dealing with the exceptions and make the rules around what supports best practice for the majority, and where do you draw that? So it just takes constant discussion and then coming back to the values really getting it done really valued. I don't mean to put you on the spot, but since you identified yourself as parents, I'd just be interested in your take, anything from your experience that
Or anything that you particularly liked or disliked about it?
resonated with you or not.
We both background, we spent 101 days in the unit, in Belfast. So once in the Royal and then to Antrim. And we've seen completely different care in both. Obviously one's an intensive care unit and one is a smaller intensive care unit with a special needs. So in Antrim, it was very closed. You were told to remove, it was a small unit, you were told to leave when doctors come around, whereas in the Royal, we were involved. We were very much involved. The notes were on the table, you read the notes. You could approach the doctors 24 hours a day if they were in the room. You were brought in with consultants, you were chatted. So we liked that when we went to Antrim and you didn't see your doctors. So it's very hard within Northern Ireland that there's a vast difference between units there. So I think you need to be involved.
I think it was because you were so used to initially being, the information was so open, and then all of a sudden it was like closed shop, and you sort of wondered why, when you were you knew all the information initially, and then now you didn't. It was hard to sort of come to terms with it. But if you had been used to not knowing the information, you would have thought nothing different.
Yes, that's the way it
The
was.
care wasn't different. I mean, the care Joshua is fabulous now. I mean, I'm not the care from the doctors and the nurses are both fabulous. It's just how you're treated as a parent was very, very, very different. And I mean, that comes down to the needs then of the unit, and as you say, maybe different objectives, different sizes of units. So this is where we found it very different. It's hard to move a child, and then it was hard to see a complete closure between, the different units. So, I mean, we spoke openly with yourself about this, and we did find that hard. And maybe other parents don't see that because they don't move.
No, we hear that a lot from parents about inconsistency. The big point where they do see it is moving from one unit to another, and particularly when it coincides with the baby getting better and going to a lower level of care and not needing so much support. But in fact, that can often feel like abandonment, and that nobody's caring about my baby. And yet again, especially if there's not so much information sharing. But even within a unit, the variability about, on one day to the next, one rotation of physicians to the next, because they rotate on a different scale than nurses. Sometimes if there's primary care or not primary care, parents are often on pins and needles about, well, I did this yesterday, can I do this today? Or will, so-and-so's on, that means that they're gonna.
That goes on a lot.
Yeah, and that's a real challenge. I mean, because again, it's the inconsistency more than, whether it's right or wrong what they're doing, that I think is particularly emotionally draining and wearing. And and no wonder it adds to the stress.
We just had that at the weekend in our place because the parents who were in and they'd seen the consultant over the weekend and they'd been in the unit previously, so I think they had been aware of how it all runs. And the relief on their face whenever he told them that he was the consultant on for the week and that he would be seeing them right through, you could just see it instantaneously. It was like, oh yeah, it's the same person, so it'll be same right across the board.
So, one way to deal with that, and I've seen it done successfully, is make the parents the consistency, right? And to have everybody really respect that the parent really is keeping close track. They're really motivated and they're really good at keeping, and they can be the information conduit to make sure that the handover around the baby status is, everybody has the same story about what, when the next surgical check is or what the history is on this. Why don't we capitalize on that instead of, working around that and trying, it's a very complex team that has to take care of a baby.
I think you're right that it's good to ask the parents even at the rounds when, especially when different nurses takes over the care of your baby that's never done it before and they've maybe been semi-informed about him. And Joshua used to dip quite low, but would come back up. Sometimes it didn't, but sometimes it did. So when a nurse came around, he got quite scared when he sat where he was quite low. So you'd say, well, that was Joshua and this is his normal flow. So they then settle down a wee bit. But when you've got a new nurse on, that didn't know this, they panicked. So as a parent, we'd obviously lived through that for days and days and days until he had a ligation and things. So we knew he would do this, and it would be a rare occasion where he basically needed to be resuscitated. But so I think as a parent, you get to know your child and you get your safety lines and you know where your barriers are. Whereas there's guidelines where the nurses and doctors maybe think that shouldn't happen. So I do think as a parent, you're there. I mean, I did spend quite a long time in both neonatals. I wasn't one of those mothers that didn't that stayed at home. I basically stayed in hospital quite a lot of the time. So you do get to know the traits of your child.
So a huge untapped resource.
Alison and then Maria.
Just, good to see you both again. Tiny Life and I carried out a piece of work on behalf of the Neonatal Network in January with 5 focus groups, and we met with 40 parents who cared for 56 premature babies. Firstly, a lot of what you were saying really resonated with me, and the information that was coming out in terms of what parents are telling us about neonatal units, the level of care and how they're included or not within their units. So a lot of what you're saying in some ways is not a surprise. It tells us how far we have to go. It's good to see some of the parents here. Inconsistency in units, how information is shared. Sometimes it's the small and simple things that parents need to be listened to, etc., that are actually the most important. And you have to think not just of the short-term implications when the baby's in the unit, but the longer-term implications for that family when they go home. And that's crucial.
Yeah, can I just add the wealth of the piece of work that Alison has led in relation to parent involvement and those nuggets and gems, and while staff are and the network are keen and more than keen to be consistent across all the units, it is something that they are working with, and I suppose it's very complex. The interaction with other service areas and other departments and other professionals.
Yeah, it just kind of ripples
out.
out.
It's huge, but there is work in all fronts happening in relation to bringing some consistency to guidance and procedures and policies, and hopefully that will support the cultural changes that's needed.
That's great. I know this would be a topic of a whole, we could go a whole other hour on this, and we won't. But as you're doing that work, I have to ask the question, especially if you hit a roadblock, like, the retrograde movement, in terms of, you have to ask, like, why, and, why is it the staff are becoming so rigid and rule-based and things like that? And there's some really interesting work going on in the safety culture research area. So people that look at, at implementing, trying to, change the culture around patient safety more broadly. And they're, Brian Sexton and his group are really looking at the caregivers and what happens with them in terms of their level of burnout, in terms of the reward structure around, how they feel good about their job and what supports are there for them. So again, you'll hear from nurses, it takes so much energy. I have 2 patients, I have the parents and I have the baby, and how do we support a structure that is able to support family-centered care? It might not just be putting more without figuring out how to better support that. Nurses need some off-stage time where, or if the pressure to get the tasks done and the way the staffing is that, the reason when you ask, well, why aren't parents allowed and encouraged to stay during change of shift and help with the handover from what they observe? Well, I've got to switch over my 5 lines, I've got to finish the charting, I've got, there's like all this stuff around the workflow that we haven't figured out. So I hope one of the message that comes out from this is not to just, we're not there yet and we've just got to do more, put more burden on the staff without figuring out what are the barriers and where the points and opportunities are and where we can be creative. But motivation is halfway there, and if we can get everyone to share the same value and to appreciate the importance on that level, then I think we can really make good progress.
Maria, I know you wanted to make a point there, and then there's another one.
Thank you for your talk. I was intrigued by how equitable a picture you painted of fathers and mothers in the neonatal unit, and I welcome that greatly because I saw it from your title, Family Centred Care. But when we did a research study here, which was kindly, generously supported by Tiny Life, along with a PhD student, his name is Kathleen Deeney, of father's experiences in neonatal intensive care units. One of the things she found really was, there was very inequitable involvement by fathers and mothers, as perceived by fathers in any case. And what was very nice of our study was something that you touched on too, was the breadth of fathers' contribution during that time, whether it's an instrumental thing like baking the cookies, or in her case, I remember the narrative of, I've got to buy a new car so I can make sure I get there and back to between the regional and the smaller hospital, or the stories of, I suppose, love and concern for their babies, and fathers sitting beside neonatal units for hours on end singing row, row, row your boat as a child perhaps died. And all of those stories I thought were so valuable. But one of the things your lecture touched on as well is the structural barriers to parents becoming involved, and we talked about that in terms of the American social security system. And that was the same in her study in terms of things like paternity leave and so on, and structure that kind of involvement. But one thing your lecture also touched on was the idea of attachment theory. And you painted that as coming from the idea that attachment theory is rooted in father and mother attachment to a child. But actually what the neonatal nurses were telling Kathleen was, and she herself was a neonatal nurse, was that fathers were not invited to be involved in the way that mothers were. And there was an expectation coming from attachment theory that nurses really saw the importance of getting mothers involved. In fact, they always monitored it. And whereas they kind of sat back and let fathers become involved or not involved as an optional. And I think that they, certainly Kathleen would have pointed to attachment theory being based on mother-child-infant attachment, being taught that way.
Yeah.
And so I think if your research in terms of attachment theory and the importance of father-child attachment theory could also be brought forward into mechanisms that could be an important contribution to getting fathers involved.
Well, thank you for pointing that out. Yeah, we do have to, I think, do some re-education on more up-to-date theory, and it's very easy for us to slip back into standard stereotypes in terms of mother role and father role. But in fact, and this is not my work, but as I understand it, the biology of attachment and relationship-based care, goes across the sexes. It's not, certainly there's some specific things about the early contact, supporting, milk letdown and better breastfeeding that would be specific to the mother, but certainly, that early attachment and their early contact, produces more oxytocin, which is quote unquote the bonding hormone. The whole development of the father-infant relationship is critically important to children's development, as is the maternal-child bond and relationship. So, the more we understand from animal studies, from human studies about the biology of child development, the father plays a crucial role, and we, hold on to old stereotypes about, well, the father's supposed to go out and earn the paycheck to support the family, and that's how they show their attachment. It's not that simplistic at all, but yet that's often the stereotype.